Everyone. Hope you all can hear me. Welcome, and on behalf of the Western States Genetic Services Collaborative, I'd like to thank you all for joining our webinar today. It's the second in our summer webinar series focusing on whole exome and whole genome sequencing. Last month we heard from Sarah, and she provided us an introduction to whole exome and whole genome sequencing, and that webinar recording is available on our website. Next month, date and time to be determined, we'll hear from Kevin Fitzgerald, a PhD at Georgetown, who will speak on ethics of genome sequencing. And today we have Naghmeh Dorrani, and she is a genetic counselor and study coordinator at UCLA, and she's been there for the past 15 years, working in pediatrics and adult genetics. And clinically, she's been involved with whole exome sequencing since they started it over at UCLA in about January of 2012. So before we get started, just like to remind everybody to mute their phones if you're calling in by phone, just to avoid any interference. Your phones are all muted anyways, but just to help prevent any kind of echoing. And then if you have any questions, feel free to type them in the dialogue box. And we'll just have Naghmeh, she can either address them when she pauses, or I'm sure she saved quite a bit of time for questions at the end. So with that, I will hand over to Naghmeh, and let me go ahead and change and make sure we can hear you.
Okay, can you hear me?
Yes.
Yes, okay, so I have to in. And okay. Yeah, can you see my slides?
Yes, then we can see your slides.
Okay. Thank you, Jen, for the introduction, and thank you for the audience for attending this. First, I think I have to start with the disclaimer, which I have none. I just wanted to let you know that I'm a genetic counselor at UCLA for both the genomics lab as well as a clinical genetic counselor in pediatrics, where I see both adult and peds patients. Being on both sides actually has given me kind of, I would say, a unique perspective on this. I came to appreciate the complexity of issues on both sides. So what you're going to hear in the next 50 minutes or so is my role actually as both a clinical genetic counselor in the lab and in the clinic. And my talk is going to be about clinical stuff, and I'm not going to get into the molecular stuff of this because I'm sure that you had the introduction in the previous talk. So for the overview, I'm going to start talking about the interaction of the laboratory with the healthcare provider in the context of whole exome sequencing. I'm going to go to clinic and talk about the importance of the pretest evaluation and counseling, and of course the importance of consent, again with regards to whole exome sequencing. On the bench side or the lab side, I'm going to go a little bit into the logistics and the methods that we use and the results and how we report the results, and again go back to the clinic and deal with post-test counseling and the clinical correlation of the results, and I'm going to have some cases for you. I'm not sure exactly who is in the audience, but for people who are practitioners, genetic counselors, or physicians, you have to, I'm sure pretty much you're familiar with this linear form of interaction that we have in the clinic. It's very, very traditional in medicine that you see the patient, you suspect a diagnosis, and you try to find a genetic test for it, either a single gene or a panel of genes, and then you send for the test, you get a confirmation, it's a yay or nay, or sometimes you have to go back and test again. So pretty much, again, it's a linear form of interaction that you have. It's usually between the physician and the patient. Now in the genomic era, things are a little bit different. There is a new dynamic that laboratory actually comes into playing a role. And the role of the laboratory is in the interpretation of the data. And this is very important. I'm going to get into this in a second when I'm talking about the value of medical records and what we do in the lab as well as in the clinic. So what happens? The physician sees the patient. Patients have the blood drawn. The blood gets to the lab. It gets accessioned. The DNA is extracted. We capture exome. And again, I'm pretty sure that has been dealt with in the previous talk. We are doing exome sequencing. This exome is the coding part of the genome. It is only 1% of the genome. And we know that most disease-causing mutations known to date, happen in exome. That's the rationale for doing exome sequencing. Then we sequence, we do data analysis, and here at UCLA for the interpretation of data, we have a genomic board. And we have modeled it after the tumor board that we have in cancer. So every week we have about 10 to 20 professionals from different disciplines that they gather, and we review about 10 to 12 cases. And these people from different disciplines, they include physicians from, again, different specialties, genetic counselors, molecular geneticists, cytogeneticists, even trainees in genetics in medicine. So it is a pretty interesting dynamic that we have, that everything is there, and we go over all the data, and there is a very dynamic discussion going on. And then after the decision is made, the lab reports the results. So I'm going back now to clinic and start from the time that we see the patient. What happens? The goal of evaluation is to see whether or not the patient is a candidate for whole exome sequencing. So the process, again, geneticists and genetic counselors out there, they're familiar with this process. Very, very important part of this process is review of medical records. And as a genetic counselor for both the lab and the clinic, I do this on both sides. I do this for the lab for the cases that we receive from outside, and I do this, for the cases that I see at UCLA. And this is, again, very important because we are dealing with genetics. We are dealing from head to toe. So some doctors, when I call and say, could you send me, medical records? I say, why do you need medical records? I told you that the patient has developmental delay. It doesn't help me. And I tell you again, as we go forward, why is it important to have detailed medical records and to have a good phenotype for the patient. We want to know what genetic test has been performed before, and then we get to genetic evaluation. Medical evaluation is, what usually the physician performs, but the family history, of course, is a specialty of genetic counselors, and I can't emphasize enough that how important, again, this family history is, because everything that they find should be interpreted in the context of the family history. As you know, this is, again, genetics. And when I talk to physicians outside and say that, I need some family history, most physicians, especially if they're not in genetics, they do not take pedigrees. They do not ask about family history, or they just concentrate in one system. And that's not going to be helpful in genetics. So my 2 cents when I teach or when I talk to residents, interns, is that it's a good thing that you learn to do a quick pedigree and to see if anything else is going on in the family. From the family history, we can see the mode of inheritance. We can see who else we have to test in the family. So very, very important. And physical evaluation, as you know, it can give us a good understanding of what the symptoms of the patient is. American College of Medical Genetics came up with this guideline to say that when we have to do clinical exome sequencing, and it reads as the phenotype of family history data should strongly implicate that a genetic etiology is behind this, but the phenotype do not correspond with the specific disorder. And also, it should be that they also say that in the recommendation that pretty much you have exhausted, any testing that is possible, and you couldn't find a diagnosis for this patient. basically that's where they say that, whole exome sequencing should happen. To summarize that, so the goal is to use this technology to diagnose rare genetic disorders, and you have used anything else that is out there, and it hasn't yielded any results. And I put this in quotation mark because now the thinking is that we, instead of doing this to prevent unnecessary costly testing, we probably should move this into the first tier instead of trying to send thousands and thousands of dollars of tests. And you can see some examples that I have for you that we have spent so much money on different testing, and it hasn't yielded anything. So why not move this at the first tier instead of doing all those unnecessary tests? So the case one, just to go over some of the points that I talked about, this first case is a little boy that we saw, in clinic who presented with contractions of extremities, left hip dislocation, which was noted at birth. You can appreciate some dysmorphic features. She has down slanting papillary fissures. She had low set ears. Basically, if you draw a line, from the corner of the eye to the ear, it should be a straight line. But she had down slanting, so it looks normal here, but it was really low set. And as he has also a short neck. Basically, he didn't have any neck. There is this club feet. There is cutis aplasia, which is a scar on the top of the head, and undescended testicles. The mother had an uneventful pregnancy. It was a C-section because of a breech presentation. Everything was normal at birth. No problem in birth weight or length or head circumference. He had laryngomalacia, which is when when the soft immature cartilage of the upper larynx collapses inward and during inhalation and causes airway obstruction. But it was resolved at 2 months, so we were not concerned about that. He had X-rays, and which was considered with arthrogryposis, which means contracture of the joints. We did an ultrasound of the pelvis, and it was normal. This is a pedigree. That's basically, this is the little boy, and the parents, as you can see, they're very young. There's nothing in the history. There is no consanguinity. They're not related, like first cousins or anything. And so there's nothing going on in the family history. As far as genetic testing, we look at the chromosome, which were normal. We look at the chromosome microarray, which is a higher resolution of chromosomes, and that was also normal. These genes were available, and for arthrogryposis, we tested them, and we didn't find any mutation. We still think that this patient is a good candidate for whole exome sequencing because, as you saw, the parents are very young. They want to have more kids, and we want to give them a better risk and options, for future pregnancies. The second case is actually a sad case. We saw this 17-year-old boy who had sudden cardiac arrest when he was watching TV in front of his parents. He had ventricular fibrillations, and he was referred to genetics for evaluation. History was not really something that impressed us. He had only 2-3 chest pains, and no history that could really guide us anywhere. All these studies, like electrocardiograms, electroencephalogram, MRI of the heart, CT scan, everything came back normal. But if you look at his family history, and I apologize that this is a little bit faint, this is the patient, and you can see that his father at age 43 had hypertension. But look at his family history. His father, his uncle, and this aunt, age 66, 72, and 71, they all had congenital heart failure. This uncle had a heart attack. This aunt had arrhythmia. This other aunt had a syncope, heart attack. To make things more complicated, on his mother's side, you see this uncle who died at 60s, in his 60s, of heart attack, and mom at age 62 had coronary bypass. So you look at this. If you remember the ACMG guideline, it says that something that smells genetic. This is something that you should consider for exome sequencing. I mean, this is very strong. Although the patient did not have a good history, this family history tells you that something is going on. And look at all this is before whole exome sequencing. Look at the number of genes and panels that we sent on these patients. I do not give you a number of how much it cost, but it was a lot, thousands and thousands of dollars. And still we think this patient is a good candidate for whole exome sequencing because, since then many other genes were known, and, some cardiomyopathy patients are presenting with similar phenotypes. So, and look at, going back, look at, there is a sister who's 10 years of age, and, she's at a brother who's 10 years of age, and she's at risk, and, this aunt is at risk. So, there is, a value to do this testing. Now, now you decided that, you want to send this test, and the patient is a good candidate for whole exome sequencing. This test is changing the paradigm of genetic testing. It's no longer limited to a single gene or panel, but rather we are analyzing exons of 20,000 genes at the same time. And we are significantly enhancing the data generated from individual genome, which has put forth a lot of questions on how to deal with this huge information and unexpected findings that might actually complicate clinical utility and patient benefit. So there is no consensus about ethical issues, and next month I think you're going to hear about the ethical issues with regards to whole exome sequencing. So there is, again, no answer for all the questions that we have, but there is consensus about one thing, that if you want to do whole exome sequencing, you have to do it in the context of a consent. So all patients should be consented for this test. So at this point, there is, again, consensus among all the labs that assigned consent should go with the sample. Otherwise, the labs will not run the sample at all. The points that I have included here are just the process of consent that, some of you might be familiar with if you're doing research or any other type of consent. So basically, you have to review the benefits, limitations, and risk of the consent. I put that it should be obtained in a quiet and private setting. You do not want to just give your consent to the patient when they're walking out the door and say, well, by the way, you're going to sign this and go to the lab. You want them to understand what you're doing and what they have to expect from this test. And it's always a good practice to give a copy of the signed consent to the patient. And I emphasize on this because a lot of times, again, I'm working on both sides. The lab does not receive it, and they contact you, and you do not have one in the chart, and then the test is not going to be run. So again, it's a good practice to have it, one copy in your chart and give one copy to your patient. In terms of doing the consent, going over the process of consent is not any different from what we do in genetic counseling in general. We have to evaluate our patient's knowledge, level of knowledge, and just modify our counseling, based on what they understand. We have to define terms and do not take it for granted that they necessarily know what genes are or, what mutations are. Do they understand the difference between mutation and the variant? So we have to define terms for the patient. 3 important things should be included in any consent process: why a test is done, how a test is done, and what is implied in it. So as why of the test, this is to identify the cause of disability or disease. And this is very important. I have a lot of calls that I get even from physicians that they say that, can you do screening for this person? And I'm like, what is the symptoms? These are the patient. It's not the patient, they don't have anything. This is not a screening test. It's not for people who do not have, quote-unquote, any symptoms. It is a clinical test and it's a diagnostic test. So we are not using it for normal people, again, quote-unquote normal. How the test is done, it is a blood test. It does not require too much blood. It's like any other regular genetic testing that we do. The limitations of the test, probably, this is one of the most important facts that the patient should know, and this is one thing that I want the patient to walk out of my office and remembering if they do not remember anything, for the, for the whole counseling session. I want them to know that this test is not 100% to detect or to find the answer to the question that we have. As we talked about, this is exome sequencing. We are not sequencing the whole genome. So if there is a mutation in other parts of the exome, other parts in the genome that are not in the exome, non-exomic mutations, in other words, if they're happening in introns, in promoters, we cannot find those mutations. There are some form of mutations like triple repeats, for example, with Fragile X, Huntington disease. We cannot detect those mutations by exome sequencing. So the patient should understand that there are limitations in the technology of this test, and also that our interpretation is only limited to the knowledge that we have today. We might find something that is a variant of unknown clinical significance today, and tomorrow it becomes significant, or tomorrow it becomes benign. So our knowledge, again, is very limited, and we might not know of some genes, and that's why that some laboratory even offer to review the results on an annual basis and to just reinterpret the data. But again, it's very important for the patient to understand these limitations and do not come back thinking that, okay, you looked at 20,000 genes and you're telling me it's negative, so I do not have a genetic disorder, which is not the case. As far as the risk, the patient should understand that sometimes the results might come back ambiguous, and we have to test other family members to clarify results. We might find about genetic risk of disorders that are not related to the clinical concern that we tested the patient for. We might find out about genetic risk for disorders that they do not have treatment, like late onset disorders. And we might find out about biological relationships like non-paternity, non-maternity. And we have to explain to the patient that if there are in situations like this, it might cause anxiety and distress to them. So the patient ought to have the testing with full understanding of this. I like to put the turnaround time as a limitation of this test. It's 3 to 4 months, and that's at least for UCLA at this point, and we are trying very hard to reduce this turnaround time. But you can imagine if there is a backlog or anything, you can go even more into 5 months or so. So this is one of the problems that you cannot get an immediate result. So what will report it? That's also important for the patient to understand. There is no standard reporting. There's no standard for reporting among the labs. There is, again, no consensus on that either. So at this point, reporting of the results is lab specific. 3 different findings can be reported in an exome lab, like any other genetic testing. The first one is a causal mutation. You find a clinically significant mutation that is associated for what you were looking for. So that's pretty clear. You can see variant of unknown significance. I'm going to get into that. And incidental findings that probably if you are following and the whole exome sequencing in general, you know something about it. And I'm going to get into it and all the discussion that goes around this. So incidental finding in March 2013, American College of Medical Genetics came up with this recommendation that, first of all, the definition of incidental finding is that these are results that do not relate to the indication for ordering the test, but they are of medical value or utility to the physician who orders the test and the patient. So their recommendation is that we have to report mutations in 57 genes, and actually recently they have dropped 1 gene, so it's 56 genes. If you look at this recommendation, the list of the genes are in the back of that recommendation, the publication, and most of these genes are cancer genes. So what they are asking is that you go actively look for these genes, and if you see a mutation in them, report that. These genes, basically, they justify the recommendation saying that these genes have preventive measures and treatment for them. Patient might not experience symptoms for a long period of time. In other words, it's a late onset disorder. And the mutations are well recognized or known to have a strong link of causation. Well, this has been an issue of debate because the way that they put it, it sounds very clear, but it is really not clear that what you're going to do about the variant of unknown significance that you find in these genes. In other words, if a mutation or a variant that you find it has not been reported before in the literature, what do you do with them? Should you report it? Should you just leave it alone? So it's not that they have given you a list of mutations, say that, go look for this mutation. To just say that you report mutations. So that has been one of the issues that has been, again, the issue of debate between the labs. The second point that they have in this recommendation is the value of pre and post-test counseling that nobody is arguing about. We all agree about this. The third point is that they state that the ordering physician should be able to interpret the incidental findings with the medical and family history. I put this into question, and I say that, is it possible that everybody knows about everything? Imagine that a pediatrician is, sending this test for developmental delay. Why should we expect that, the physician should know about cancer risk and, the screening of it and, be able to know and interpret, everything that it is reported in this test. To me, it's a little bit problematic. Even in genetics, sometimes we have a problem, understanding, the genetic results, much less that, you ask, every other specialty to understand it. The fourth point also I have, and I think many people in the genetics community have problems with it, and is that, they state that pediatric patients should receive these results regardless of their age, and they do not even give an option to the patient. And so, in other words, they eliminate the value of autonomy from this. And I think that's the very important premise of genetic counseling that at least where we are practicing in the U.S. that we are practicing it. So where is the autonomy in this? Maybe, the family does not want to know about the risk of cancer. And there are a lot of people out there that, they do not want to know about everything and anything that is happening in their genome. So again, this is also problematic and maybe should be, should be at least be a subject of debate and, see if we can change it or at least give the option to the patient. The last point is that they state that there is an estimation of 1 to 2% that for patients who have this genomic sequencing will have an incidental finding. From the discussions we have had with different labs that offer exome sequencing, we understand that this data is not correct, and everybody reports, sees that their internal data is higher than that. So, what is the consensus? There is no consensus. Still, the labs are doing, are reporting the way they want to do. Not everybody is reporting all this, are following these guidelines. The way I'm hearing it is that, these guidelines are going to be, this recommendation rather, is going to get changed because, there is a lot of feedback from the community. As far as UCLA, we have decided to put an option about whether or not the patient is going to wants to have the incidental finding and just wait for the future and see how this recommendation is going to change. Now I'm going to take you back to the lab and talk a little bit about the logistics of what happens in the lab and the interaction that we have with the physicians. The next two slides I have, it's about gene panels and exome sequencing, and I put these two slides because I get these questions from people that what is the difference, and should we order gene panels or should we order exome sequencing? A gene panel, I think the best analogy that you can have is a bookshelf. So you have a bookshelf. It's a limited space, and you have probably the books that you like the most. And there's just few books in there. It is very useful, but again, there is a limit to it that that you can count the number of the books. And again, it's only the books of your interest. Now imagine the library. Imagine the Library of Congress. This is the library in Dublin. If you want to find a specific lab, you have to do some search. So it's way more comprehensive than just a bookshelf. And again, where do you have to order exome sequencing and when gene panel? It very much depends. Sometimes the coverage of a gene and the exome is not that great. So my advice to people who are looking for a specific gene is that go and ask the lab whether or not, ask about the coverage of that gene and make sure that gene, first of all, is covered in their exome, and second, that, the coverage is good. Because with the panel, they sequence the gene, so it is a better chance of finding a mutation. But again, exome can have the same coverage and go beyond that gene. So it's up to the physician, ordering physician, or the genetic counselor to do, some search and decide which one is a better choice for their patient. Now, you remember that I talked about the value of medical records and how is it that we are using it in exome sequencing. So you understand that we have about 20,000 genes, at least an estimate of 20,000 genes in our body. And it's about 3,000 genes that are known to be associated, clinically associated with disease-causing genes. Let's put it that way. So this test is very comprehensive, but at the same time, it's not haphazard. The way that we do this is that we create a primary gene list. And the way that we create this primary gene list is that we use the medical records and the phenotype of the patient to find the genes that correlate with the symptoms. So I have an example for you. We have a patient with 3 phenotypes, and I've used developmental delay, dysmorphic features, and epilepsy, which is the most common phenotypes that we see in genetics clinic. So each of them, have, their own genes, 250 genes for 250 genes for developmental delay, 150 for dysmorphic features, 450 for epilepsy. And if we do not go and say that, okay, let's see what is, the genes that are shared between these 3 phenotypes. The way that we do it is actually we include all these genes in our primary gene list, and we come up with 680 genes that become the focus of our interpretation. It doesn't mean that we do not look at the rest of the genes, but these genes specifically are important to be analyzed. So you understand how important it is to have a good phenotype and to have as detailed as possible, a list of symptoms that the patient has, so we can have the most permissive primary gene list possible. The second part is, variant classification. How do we call that, something is pathogenic, something is like pathogenic, and so forth? So I have 4 columns here for you. Non-pathogenic or disease-causing, it's a slam dunk. There is a complete phenotype. The way it's the presentation of the patient, you definitely know that this gene is related to the phenotype, and there is literature about it. There is the allele frequency, or the proportion of this variant in the population is very rare, usually less than 1%. There is an effect on the coding sequence, or it affects the, in other words, the amino acids, and therefore the protein that is made by the gene. So it is slam dunk. We know that this is a causing mutation. And a good example of it is the Delta 508 that we all know in the CFTR gene that causes cystic fibrosis. So you see that the patient is has failure to thrive and is coughing, you know that this is the mutation. Likely pathogenic, so for likely pathogenic, you know that the gene is known, and you know that this gene has been reported to cause a certain phenotype. But this specific variant that you're seeing has not been reported before. It is still rare, and it affects amino acids, and a good example of it, again, is the collagen 2A1 that is associated, that is causing achondroplasia, but you see a new de novo mutation in a patient, and so it is likely pathogenic. You cannot really say for sure that it is pathogenic until there are more cases reported about it. Variant of unknown significance, the third column, this is the headache of the lab and the counselors. The counselors in general, physicians when they do the genetic counseling. So how is this defined? I cannot give you a definition for it, but I can give you an example. Like just 2 days ago, I had a patient that I saw for seizures. And we did a whole exome sequencing, and when we had the data, we had a mutation in a gene that is well known to cause seizures and developmental retardation and all that, and we were very sure about it. But at the same time, we find a variant in another gene that causes Griscelli syndrome, and that's an immune, a neuroimmune disorder. We were not aware of the patient having any immune deficiency or anything like that, but the neurologic symptoms reported in that disorder is very much like what the patient has. And this variant that we're seeing, was not reported before. So what do? It's a variant of unknown significance. It has part of the phenotype. And we call the variant of non-significance because we really do not know whether or not it's causing the phenotype of the patient, and at the same time the variant has not been reported before. So yes, it went to the report, and I saw the patient, and we tried to look for some of the symptoms that are reported in the literature. There was no skin rashes or anything like that, but at the same time, you refer the patient for immunology to make sure that we are not missing anything subclinical. So the counseling for that, as you can see, it becomes very complicated. Incidental findings, we talked about it. It has nothing to do with the phenotype that you're seeing in the patient. And a good example of it is that you're seeing a patient for developmental delay, but at the same time you find a BRCA variant in the patient that has been reported to be disease-causing. And the benign variants are just, we know that they're not related to the phenotype, and it's very common in the population, and they have no effect, usually no effect on the coding sequence, and they're mostly SNPs variants or a single nucleotide polymorphism, and we do not report this. Another point that I want to emphasize is that on the clinical part is that one thing that is very important about exome sequencing, or I should put it this way, that the best way of doing whole exome sequencing is to have the patient and the parents tested at the same time. And the reason for that is that you actually improve the hit rate with having a trio when you have the parents and the proband. And the reason is that you can actually detect the de novo mutations. In other words, when you see something new in the patient, you will not know whether or not this is new or is coming from the parents. So you cannot really interpret the data if you do not have the parents. So this is one scenario. The other scenario is about compound heterozygous. So you see two mutations in the patient for recessive disorders, but again, you cannot determine the phase. You do not know whether it's coming from mom or dad. So there is a lot of value of doing a trio sequencing, and I cannot tell you how much it can help in giving the physician a good interpretation of the data and give a good conclusive reported to the patient. We can generate, even if you send, the patient without the parents, we do the analysis and we give you the data. But, we say that, we did not see anything because we cannot really say anything. We cannot say anything about whether or not, a mutation that we saw was de novo or compound heterozygous. So I really urge that, for the physicians out there, if they want to send, especially in pediatric settings, that the parents are available. If it is possible, it is worth to go the extra mile and get the parents' sample sent to the lab for testing as well, at the same time with the child. And this is an example of, from UCLA. The data that we have, we tested 328 cases as of beginning of August, and look at the rate that we have for diagnosis for trio versus proband only. We almost double. You can see that it is almost doubled, when you have the trio. And so again, very important. In here, we had a potential diagnosis, but again, we did not know how to interpret the data. And here you can see that we did not find anything significant in the patient. And the novel gene discovery, you can only see it if you have novel gene discovery. Means that you see a gene that somehow is related to the phenotype, like either there's an animal model for it, or there is the gene has been reported to be in a pathway that might cause an effect to the gene of interest. So these are stuff that you can report when you have trio. And here is also, the breakdown of diagnosis that you can see that the diagnosis is 50% for de novo when we have the trios, and compound heterozygous is about 23%. And this is again internal data from UCLA. Now we get to the post-test counseling. What will happen? So the scenario is that either we get a result, and we get a result that is negative, or we get a positive result. If it's a negative result, a lot of people think that, okay, so we are done and there's nothing to report to the patient. I strongly recommend that you have your patient come back and talk to the patient again about the limitation of the test. Again, the turnaround time for this test is 4 months. Patients do not remember that what negative test results mean. And the last thing you want is that, they think that the test is negative and they do not have a genetic disorder. And a year, 2 years from now, they go and get pregnant and they have another affected child, and they come back and say, you told me the test was negative, but nobody explained to me what a negative test is. So a negative test does not mean that the patient does not have a genetic disorder. A positive result, if we find a mutation, is very straightforward. Genetic counseling depends on the mode of inheritance. If it's autosomal recessive, we go through the counseling, 25% recurrence risk in offspring. If it's dominant, 50% risk of recurrence. And if it's X-linked, depends on the gender. We do offer reproduction options, prenatal testing depending on the scenario. We talked about natural history management, prognosis, and of course we provide resources to the family. If we find a probable disease-causing variant, like a variant of unknown significance, what is it that we can do? Like the example that I gave you, we try to do clinical correlation. We want to see if the patient has extra symptoms that is explained, can fit into the finding that we have. We might want to test other family members sometimes to see if there is a segregation with unaffected families. Sometimes there are people who are doing research on that gene. We can refer the patient, for to those researchers to see if there is anything that they can tell the patient extra to what And sometimes you have just to wait and to see whether or not there are more findings about it, and years from now whether or not they become benign or pathogenic. So I want to end with some case examples for you. Case one, is a 6-month-old male with developmental delay who was referred to genetics for evaluation. He had severe constipation. He couldn't sit or roll. He had hypertonia in the upper extremities, a lot of dysmorphic features. The most prominent one was the big nose and large mouth. No pregnancy issue, a family history was not contributory, and mother had concern about Angelman syndrome, but the head circumference was normal, and you know that the Angelman syndrome people with Angelman syndrome have a small head. There was no seizures. Mom sought, so many different routes to make diagnosis for this kid. They went to this lab and paid, and God knows how much to do this. I don't know what they call neurogenomic profile testing, and the report was missing the liver detoxification gene. It was totally in nonsense. Genetic study, chromosome microarray was normal. We did exome sequencing 6 months after we saw the patient, and we found a de novo mutation in the TCF4 gene and the diagnosis is Pitt Hopkins. And this is briefly the clinical features of the syndrome. And I don't have a picture of the patient, but if you look at the patient, he looks exactly like one of these pictures. And the family was very happy, very, very happy about having this diagnosis. They went on to do fundraising, and they have actually raised fund a quite good amount, for research and treatment. So they were very happy to hear about the results and the fact that their odyssey has ended. The second case is about juvenile amyotrophic lateral sclerosis, which is a neurodegenerative disease that affects the nerve cells of the brain and spine. And people with this have difficulty swallowing, they have a weakness, they have twitching of the muscles, and the average survival rate after diagnosis is 2 to 5 years. So this was an 18-year-old female who was presented to genetics actually to neurology for evaluation. She walked normally as a toddler, and she never ran well. She was clumsy, and she had weakness of the leg, and she couldn't participate in physical education. She was fatigued. So neurology gave actually this patient an ALS diagnosis, but because the patient was not fitting that well, they wanted to do an exome sequencing. And family history, there was nothing. Parents are first cousins once removed, they're Persian descent, and on the exam they found that there is this tongue fasciculation, and there was hyperreflexia in the arm and legs. So the results show that this patient has a triple AS mutation in the triple AS gene. That was the first time that I was hearing about this. And the funny thing was that the neurology was sitting in the board review, and we were talking about this, and say achalasia, which is swallowing difficulty, and this endocrine problem, and electremia, and so we were asking about, does your patient have this? And I said, oh, by the way, yeah, my patient, he had swallowing difficulty years ago, but I thought that, it's part of ALS. I don't know if there is an endocrine problem. I never thought of that, and I don't know if she can cry or not. So let me go back and see whether or not the patient has that. And actually, so the achalasia was part of it. The patient did not have an endocrine problem. It was borderline. And the good thing about it is if they have it, it can be corrected. And the last part actually was the sad part that, that this kid was labeled as being frigid and having no feelings, being teased and not crying ever. And nobody saw that, she couldn't cry because constitutionally she couldn't cry. And it wasn't that because it was a cold or, without feeling, without the feelings. So the diagnosis changed to a triple AS, and the prognosis actually is way better than the ALS diagnosis that the patient had. The third case is an 8-year-old boy that had a history of intractable seizures and global developmental delay, and we saw this patient in the hospital for reevaluation of his baseline EEG and for genetic testing. Again, pregnancy was totally normal, even APGAR. When he was born, an APGAR of 9 of 9. At 2 days of life, he started to have a posturing and increased tone. And at 4 months, he had epilepsy. And when we saw him, it totally delayed, no speech, no gait. He had kidney stones, microcephaly, small head, constipation, and failure to thrive. And nothing in the family history. There is a 10-year-old brother and 12-year-old sister that they're healthy, no consanguinity. The families of Jewish Ashkenazi background. At the list of slides that I'm going to show you, it's just to show you how much study this patient has had through years. So brain MRI in 2004, 2005, they showed something, but nothing that could really make a diagnosis. EEG that showed that he had seizures. It was we knew that he had seizures. X-ray and a cardiac echo, and that again showed some abnormality, but again nothing that we could put together to make a diagnosis. And this is the list of genetic testing that we had done from cerebral spinal fluid for neurotransmitters like the pyruvate, very long-chain fatty acids, you name it, urine organic, plasma amino acids, all this. Krabbe, we thought that it's the neurodegenerative disorder. Krabbe, Tay-Sachs, they're of Ashkenazi background. These mutations, that one physician thought this is stiff baby syndrome, and we did this mutation, MECP2, which is known in Rett syndrome. The karyotype was normal. Everything came back normal, except for this subtle stuff in imaging. So the results, finally, of exome sequencing showed that he has a de novo mutation that is in the ZEP2 gene, and the diagnosis is Mowat-Wilson. And this is briefly, again, the clinical features of it. The patient does not have exactly the dysmorphic features like this, so it was a little bit hard for the family to digest that, this is the diagnosis. To me, he has some of them, but it's not exactly like the first set of pictures that I showed you about the other patient. So, but he has the rest of the features, and again, we made the diagnosis, and another odyssey was ended. Case number 4 is this 5-year-old female with seizures and stroke and liver abnormalities, and we saw this patient who relapsed metabolic disorders, genetic metabolic disorder. Mom had C-section at 34 weeks. There was severe intrauterine growth retardation. The placenta had blood clots, and the patient started to have seizures at 1.5 years of age. There was failure to thrive, anemia, liver failure with unknown etiology. There was cerebral infarct. Development was actually, in contrast to everything that we saw, the cognition was good, and she had severe behavioral issues. And this is again the gross list of the genetic testing and other metabolic tests that was done on the patient. She had an eye exam which was normal, an open liver biopsy that actually showed nodular regeneration and marked steatosis, which is actually an abnormal retention of lipids within the cells of the liver, and it reflects an impairment of the normal process of synthesis and elimination of triglyceride in the liver. I put this just to show you that the report that we are generating here at UCLA, and you can see here that it reads that we found a compound heterozygote mutation. This is the mutation, but this is a variant of unknown uncertain clinical significance in the large gene that, interesting enough, this paper came out like literally, I think, 2 weeks before we did the analysis. And that's why we could cite that, this was associated with Alzheimer's recessive infantile hepatopathy. And this is the second page of the report, and you see that we put the keywords, and these are the words that we use to generate the primary gene list, and this section describes the mutations and the association that we found in literature. So we had to go back and review the literature, and there is only one paper, of course, and this specific variant is not a mutation that it is in that paper, but the patient has exactly the same phenotype as the 6 affected members in this family that was cited in this paper. So we are pretty confident that this is the diagnosis the patient has, and there is no treatment for it, but we are thinking, knowing the gene and knowing how it functions, our physician thinks that maybe we can have a small clinical trial, just a one-person clinical trial to modify the diet and see if we can see any changes. So I'm hoping that we can make a difference, for this patient, at least knowing that what the diagnosis is. So to summarize, the exome sequencing is bringing about a paradigm shift in diagnosis of rare genetic disorders, and it's a very powerful diagnostic tool. Pre-test counseling is very important to ensure that family understand the limitation and risk of testing. We need a detailed phenotype to do this test. Please, if you're ordering the test as a genetic counselor, as a physician, do your best to send the best clinical notes that you have, family history, to the lab. It's going to help a lot you and your patient in the interpretation of the test. I very highly recommend that you do this test as a trio, if it is possible, of course. And it is very important that you do a clinical correlation when it comes to uncertain clinical significance variants that you find to see whether or not this could be significant for your patient. With this, I end, and I just want to acknowledge my colleagues in the Clinical Genomics Center and our collaborators that make this very exciting thing happen. Thank you so much.
Great. Thanks so much, Naghmeh. So no questions have actually come in yet. Does anybody have any questions typed in? No? Okay. Well, if anybody does come across any questions, you can email myself, and I can get in touch with Naghmeh. My email is jennifer@hawaiigenetics.org. Thanks so much, Naghmeh. That was such a great overview of the clinical experience, and then it was really nice to hear your personal and UCLA's experience. So I think a lot of people took a lot out of your presentation.
Thank you.
So thank you so much. And with that, we'll conclude. This recording will be available on our website once it gets uploaded, and we'll email it out to the collaborative. So thank you so much.
Bye-bye.